All right, welcome to this rapid-fire explainer. We're diving straight into a high-yield clinical gauntlet covering pediatric surgery and diagnosis. We've got a lot of ground to cover, so let's just hit the ground running with our very first case. Okay, question 1. Which of the following is the most common type of lung cancer found in children? Is it A, bronchial carcinoid, B, metastatic carcinoma, C, bronchial adenoma, D, small cell carcinoma, or E, plasma cell granuloma?
And the correct answer is B, metastatic carcinoma. Now, the absolutely crucial point here is just the overwhelming prevalence of metastatic carcinoma over primary lung cancers in kids. To put it into perspective, the ratio of primary pulmonary malignancies to metastatic neoplasms to non-neoplastic lesions is about 1 to 5 to 60, so secondary tumors are way more common. But for your exam pearls, keep in mind that if we are talking about primaries, bronchial adenoma is the most common primary malignant lung tumor in this population, while a plasma cell granuloma is the most common primary benign lesion.
Moving right along, imagine a 3-year-old child who falls frequently and uses their hands to literally walk up their shins just to stand up. You notice their calves are bulky, and you find out a brother died of the exact same disease. What's the diagnosis? A, poliomyelitis, B, transverse myelitis, C, Duchenne muscular dystrophy, D, ALS, or E, polymyositis.
If you guessed C, Duchenne muscular dystrophy, you nailed it. Now, what's really interesting about this slide is the classic maneuver we just described. That's called Gower sign. The child essentially walks their hands up their own legs to get upright, which perfectly compensates for some really profound pelvic girdle and proximal lower extremity muscle weakness. And those bulky calves? That's pseudohypertrophy. Basically, degenerating functional muscle tissue is progressively getting replaced by fat and fibrous tissue. It's an X-linked recessive disorder caused by a dystrophy mutation, usually showing up around 2 to 4 years of age. Tragically, it does lead to fatal respiratory or cardiac failure, but catching it early is key because glucocorticoids can actually delay the progression.
All right, next up, why are children predisposed to an increased risk of developing hyponatremic encephalopathy compared to adults? Is it A, a higher brain-skull ratio, B, underdeveloped adrenal glands, C, hypoaldosteronism, D, an underdeveloped renal system, or E, none of the above?
The answer is A higher brain-skull ratio. You see, kids possess a very strict anatomical limitation. Their brain takes up a much larger portion of that rigid skull cavity, meaning there's practically no room for expansion. So when acute hyponatremia hits, water rapidly shifts intracellularly down an osmotic gradient, which makes the brain cells swell up. This physical reality is exactly why you have to avoid hypotonic IV fluids in high-risk hospitalized kids. It is an absolutely critical clinical safeguard. If you miss this, you're risking rapid intracranial pressure spikes, and that leads straight to lethargy, generalized seizures, and even fatal herniation.
Let's pivot to a newborn presentation. You have a newborn with a 1 centimeter midline umbilical defect, but no bowel is present. What's the best treatment? A, observation without planned intervention. B, observation with closure after age 4. C, silo placement. D, emergency primary closure. Or E, emergency mesh closure.
The correct choice is A, observation without any planned intervention. Honestly, the absolute standard of care here is simply parental reassurance. And why is that? Because nature takes its course and resolves roughly 95% of these cases completely on its own, as the abdominal muscles mature over the first 2 years of life. You'd really only consider elective primary surgical repair if that umbilical hernia persists past 2 to 4 years of age. Plus, unlike adult hernias, you should remember that strangulation or obstruction inside pediatric umbilical hernias is exceptionally rare in kids under 3.
Let's reinforce that concept with another quick question. Which of the following pediatric conditions usually resolve spontaneously? A, hypospadias, B, umbilical hernia, C, biliary atresia, D, anorectal malformation, or E, none of the above?
And just like we covered, it's B, umbilical hernia. They close on their own in the vast majority of cases. Now, this is in stark contrast to those other options, which are structural anomalies that absolutely require mandatory, time-sensitive surgeries. Take biliary atresia, for instance. That demands an urgent Kasai-Porter enterostomy within the first 60 days of life to prevent progressive biliary cirrhosis. You don't wait on that. And hypospadias? That's typically repaired electively, usually between 6 to 12 months of age.
Okay, moving on to a classic GI emergency. We have a 2-year-old presenting with colicky pain that progresses to bilious vomiting.
You palpate a, quote, sausage-like mass in the right upper quadrant. What is the most likely cause? A, peritonitis, B, intussusception, C, volvulus, D, appendicitis, or E, infantile hypertrophic pyloric stenosis?
It's B, intussusception. This right here is the absolute classic presentation of one segment of the intestine telescoping right into another. What happens is the invaginating segment pulls its mesentery along with it. That leads to rapid venous congestion, massive swelling, and a mechanical small bowel obstruction, which is exactly why the vomiting shifts from non-bilious to bilious. The ileocolic subtype is the most common one you'll see, so you've got to immediately recognize this classic exam triad: that palpable sausage-shaped mass in the right upper quadrant, Dance's sign, which is this empty feeling in the right lower quadrant where the cecum used to be, and finally, the ominous late finding of red current jelly stool. Proving once again that medicine ruins all perfectly good food analogies, that jelly stool actually indicates mucosal ischemia. So sticking with that exact same 2-year-old with the colicky pain, vomiting, and a positive Dan sign, what is the best investigation to confirm your diagnosis? A, an X-ray of the abdomen. B, ultrasound. C, MRI. D, invertogram, or E, none of the above?
The right answer is B, ultrasound. And this brilliantly illustrates the utility of ultrasound, specifically hunting for that pathognomonic target or donut sign. It really is our gold standard diagnostic test for this. It boasts near 100% sensitivity and specificity in experienced hands. And the best part? Zero exposure to ionizing radiation for the kid. You're looking for concentric rings on a transverse view, forming that donut sign, or a distinct pseudo-kidney shape on the longitudinal view. Plain X-rays are pretty nonspecific here. We really just use them to screen for free air, which would indicate a perforation.
All right, so we've diagnosed it. Now, which of the following is the treatment of choice in an uncomplicated intussusception? A, hydrostatic hypersaline enema. B, hydrostatic gastrographin enema. C, air enema. D, laparotomy and milking. Or E, none of the above?
The correct choice is C, an air enema. For a stable, uncomplicated case, pneumatic reduction under fluoroscopic or ultrasound guidance is absolutely the way to go. You use gentle air insufflation to literally push that telescoped bowel back into its proper anatomical position, and it has a fantastic 70 to 80% success rate. But, and this is a big but, you have to be hypervigilant for the absolute contraindications. If the patient is in systemic shock, has frank peritonitis, or you see free air under the diaphragm, stop. Those findings demand an immediate open surgical laparotomy. And if you do end up in surgery, remember the bowel has to be carefully milked backward. You never ever just pull the invaginated segment or you run a massive risk of severe tearing.
So, what actually causes this? Which of the following is the most common cause leading to intussusception in children? A, hyperplasia of Peyer's patches. B, enteric duplication cyst. C, Meckel's diverticulum. D, small bowel lymphoma. Or E, none of the above? It's A, hyperplasia of Peyer's patches in the terminal ileum. It is completely fascinating how a simple antecedent viral infection, something like adenovirus, can trigger this hypertrophied lymphoid tissue. That swelling basically acts as a structural bolus. The bowel wall catches it and propels it forward, kicking off the whole invagination process. Over 90% of infant cases are just this idiopathic reactive hyperplasia. On the flip side, secondary focal lead points, things like duplication cysts, Meckel's diverticulum, or lymphoma, those are more commonly the culprits in older kids, usually over 2 years of age.
Let's dive right into our final clinical scenario. A 3-week-old child presents with non-bilious projectile vomiting. What diagnosis should be suspected? A, congenital hypertrophic pyloric stenosis. B, acute appendicitis. C, duodenal atria. D, intussusception. Or E, volvulus. The answer is A, congenital hypertrophic pyloric stenosis. In this condition, the hypertrophied pyloric circular muscle layer gets thicker and progressively narrows down the gastric outlet. What you get is this really forceful, non-bilious projectile vomiting right after a feed, and the infant remains noticeably hungry. On a physical exam, the hallmarks are visible left-right peristalsis and that palpable pyloric olive right in the upper abdomen. Also, because they are constantly losing all that gastric acid, it induces a classic hypochloremic, hypokalemic metabolic alkalosis. Board examiners absolutely love to test that specific lab finding, so keep it in mind.
Now for a high-stakes intraoperative question.
What is the appropriate management if the hypertrophic pyloric mucosa is cut down, meaning a deep perforation happens iatrogenically during surgery for IHPS? Is it A, immediate primary repair, B, wide bore drain, C, repair and postpone, or D, repair and continue surgery on the other side of the pylorus?
And our final answer is D, repair and continue surgery on the other side of the pylorus. A Ramsted's pyloromyotomy just has to be completed to definitively relieve that obstruction. If the surgeon accidentally breaches the mucosal lumen, you can't just stop. You have to immediately repair the perforation, verify the seal by squeezing the duodenum to check for air or bile leaks, close up that initial muscle defect, rotate the pylorus 180 degrees, and safely perform a completely new myotomy on the posterior wall. Then, you maintain a nasogastric tube for 24 to 48 hours post-op before feeding. This whole sequence perfectly demonstrates the surgeon's ultimate test, balancing aggressive mechanical correction with really delicate anatomical preservation. Does the skill to cleanly pivot mid-surgery like this define the difference between a good practitioner and a master? Something to think about.